A very good morning to one and all. Today's morning session is a practice parameters discussion on the topic NeuroBehcet's syndrome, a great masquerade. Myself, Dr. Anagha, and today's session is moderated by Dr. Sayooja. We'll begin today's discussion with a case scenario. A 33-year-old male presented with recurrent neurological events of subacute onset, characterized by imbalance on walking, limb coordination, and slurring of speech over 5 years duration. Each episode was treated with steroids elsewhere with partial response. However, the patient had accumulating deficits. There was also associated history of urinary urgency and precipitancy present. There was history of recurrent oral and genital ulcers present over the last 5 years. The family history was negative. On examination, the patient had oral and scrotal ulcers present. He had scanning dysarthria. He had a left internuclear ophthalmoplegia. There was bilateral gaze evoked nystagmus present. He also had bilateral left more than right upper and lower limb spasticity with exaggerated reflexes and extensor plantar bilaterally. The abdominal reflex was absent. He had upper and lower limb incoordination along with a spastic ataxic gait with impaired tandem walking. His imaging showed axial T2 images are showing hyperintensities involving the medulla, the pons, the dorsal midbrain, as we can see here, and the bilateral thalamus. Systemic vasculitis affecting veins and arteries of any size, including the large, medium, and the small vessels. NeuroBehcet's disease is one of the more serious manifestations of Behcet's disease. Even though it is relatively rare, since it is potentially treatable, NeuroBehcet's needs consideration in the differential diagnosis of inflammatory, infective, or demyelinating CNS disorders. Coming to the history of Behcet's disease, the earliest references of the disease dates back to around 2,500 years prior, where there were reports of oral and genital ulcers in patients with ophthalmological manifestations, which was initially thought to be due to syphilis. It was 1937 that the first case was described by the Turkish physician professor, Dr. Hulusi Behcet, who described the classical tri-symptom complex of hypopyon, iritis, and orogenital aphthosis. In the trading through the Silk Road, and it was thought that the genetic risk factors were propagated by the migrant traders along the Silk Road 2000 years ago. And it was also noted that this coincided with the distribution of HLA-B51 in healthy people also, which is further supporting the genetic prevalence of around 4%. However, the prevalence in Europe and Asia is much lower, up to 5 cases per 100,000 persons. In India, prevalence studies are unavailable. This series of case reports and populations, particularly among early onset presentations. The mean age at diagnosis is around 30 years, with a range from 15 years to 45 years age. And the disease activity tends to wane with advancing age. More severe disease is noted in males more than females. Coming to the pathogenesis of Behcet's disease, the exact pathogenesis is still poorly understood. It is believed to be triggered by environmental factors in genetically predisposed individuals, which further affect the cellular effector and signaling pathways, ultimately resulting in tissue inflammation and damage. So the environmental factors that trigger the disease has been identified to be microorganisms, including bacteria, viruses, and their byproducts, consumption of histamine-releasing food like citrus fruits, nuts, and cheese, poor oral hygiene, and stress. Coming to the genetic predisposition in Behcet's disease, the first reported gene associated was the HLA-B51 allele. And it was seen that the Behcet's disease is 6 times more likely in HLA-B51 carriers. However, the risk or odds ratio of Behcet's disease in an individual that is positive for HLA-B51 shows a wide variation in Europe and Asian population. Hence, a convincing evidence for a direct role in Behcet's disease is still awaited. The other genes that are involved in the pathogenesis of Behcet's disease include other genes involved in the T cell mediated immunity. That is, genes involving the T helper 1 and T helper 17 cell polarization, genes in natural killer cell activity, and genes involved in cell chemotaxis. Yes. So the crux is that presence of HLA-B51 is only a supportive evidence for the diagnosis of Behcet's disease. Is not required for the diagnostic criteria. So in a genetically predisposed individual with exposure to environmental stimuli, there is triggering of immune response. The immune response is mainly CD4 T cell mediated. The CD4 T cell further recruits T helper 1 cell and T helper 17 cell. The T helper 1 cells recruits inflammatory cytokines, including the TNF alpha interleukins, and it also triggers the CD8 and natural killer cells, which further results in cellular cytotoxicity. It also recruits the T helper 17 cells, which further recruits neutrophils. So one thing we have to remember is that neutrophils are the main infiltrating cell type in Behcet's disease, which in comparison to other systemic vasculitis is lymphocytes. And these neutrophils produce excess reactive oxygen species and also releases neutrophil extracellular traps. These neutrophil extracellular traps also predisposes the disease to procoagulant state, resulting in venous thrombosis and other procoagulant manifestations. So these lymphocytes and neutrophils, once recruited, they result in the destruction of the blood-brain barrier, and it also recruits cytokines. So this triggers an auto-inflammatory cascade. That is, this neutrophil and lymphocytes recruits the inflammatory mediators, which further causes a damage and further results in recruitment of further inflammatory mediators. And it also has an also triggers autoimmunity episodes. That is, this debris from this damage from the neutrophil and lymphocytes further causes a mitogenic effect of the plasma B cells, resulting in recruitment of autoantibodies also. So all these inflammatory process results in neuronal demyelination, ultimately resulting in neuronal loss and degeneration. Coming to the clinical manifestation of Behcet's disease, the most common clinical manifestation is oral ulcers, which is seen in around 98% of the patients. This is a diagram showing the oral ulcers seen in Behcet's disease. The next common manifestation is the presence of skin lesions. The classical skin lesions described as pseudofolliculitis, the presence of papulopustular acne-like lesions, as we can see in this figure, the presence of erythema nodosum, and pathology test positivity. There are also around 60 to 65% of patients also report presence of genital ulcers, and there is also a rare manifestation with epididymoorchitis also. Arthritis is another presentation which can occur with knees, ankles, wrists, and the ophthalmology manifestations. The classical presentation include the presence of hypopyon, non-granulomatous panuveitis, and retinal vasculitis. Gastrointestinal manifestations has also been described. Ulcers, abdominal pain, temperature, perfusion, or both. And cardiovascular manifestation has also been described with the presence of valvulitis, myopericarditis, and coronary arteritis. And the disease has also predisposition to the presence of arterial and venous anomalies, that is arterial aneurysms, arterial stenosis or thrombosis involving arterial cells. So, venous anomalies including deep vein thrombosis of the limbs, pulmonary and the suprahepatic veins, and also superficial thrombophlebitis has also been described. The CNS-related manifestations we'll be discussing in detail. Coming to the diagnostic criteria for Behcet's disease, the first diagnostic criteria was put forward by the International Study Group in 1990. So this requires the presence of recurrent oral lesion plus either 2 of ocular lesions, skin lesions, or a positive pathology test. So this criteria has to be as the presence of minor, major, or herpetiform oral aphthous ulcers recurring at least 3 times over 1 year. Presence of genital ulceration is defined by genital ulcers or scarring. The presence of skin lesions described only by the presence of erythema nodosum, pseudofolliculitis, or papulopustular lesions, or acneiform lesions in a post-adolescent patient who is not on glucocorticoids. Ocular lesions is defined by the presence of anterior or posterior uveitis, presence of cells in the vitreous on slit lamp examination, or the presence of retinal vasculitis. Vascular lesions are arterial or venous thrombosis or superficial phlebitis. And as a combination of neurological symptoms or signs in patients with definite Behcet's disease. It is a rare and more serious manifestation of Behcet's disease. The prevalence of patients with Behcet's disease, and males are more affected than females. The onset is like in Behcet's disease around the 3rd decade of life. And the NeuroBehcet's, the neurological manifestations have been described at a mean of 5 years from the onset of Behcet's disease, but some patients can also present directly with neurological manifestations. In pediatric age group, the median age of presentation is around 12 years, and in pediatric age group, the presence of constitutional symptoms like recurrent fever is more described than compared to adults. So coming to the clinical presentation of NeuroBehcet's, so there are central nervous system and peripheral nervous system manifestations described, and central nervous system manifestations are the most commonly described. And the central nervous system manifestation can be divided into parenchymal and non-parenchymal manifestations. Parenchymal manifestation can present in a multifocal or diffuse manner involving the brainstem, spinal cord, or cerebral hemispheres. Optic neuropathy has also been rarely without intracranial hypotension, and there is also presentation with intracranial hypertension in the absence of cerebral venous thrombosis also. The other non-parenchymal manifestations include the presence of intracranial, extracranial aneurysm, or presentation with an acute meningeal syndrome. And NeuroBehcet's can also present with mixed parenchymal and non-parenchymal disease. Or ophthalmoplegia, sensory neural hearing loss, which is described in around 50% of patients, facial palsy, which can be UMN or LMN, and lower cranial involvement is less commonly described. So among brainstem manifestation, an intraaxial involvement is more common compared to involvement of the cranial nerves. Coming to the hemispheric manifestation, common hemispheric manifestation. And chronic NeuroBehcet's disease can also present with dementia. Spinal manifestations are less common compared to intracranial manifestations, and they can have a primary or secondary progressive course, and they carry a more poor prognosis when compared to intracranial manifestation. In spinal cord, cervical and thoracic cord is more involved, and it's usually presenting with a longitudinal extensive transverse myelitis. And there is also rare case reports of anterior spinal artery syndrome also as a presentation. Coming to the non-parenchymal manifestation, the most common is the venous involvement with the involvement of the cortical venous sinus with or without the presence of intracranial hypertension. As I've mentioned before, intracranial hypertension without evident thrombosis has also been described. It more commonly involves superior sagittal sinus, transverse sinus, deep cerebral veins, and the cavernous sinus. Arterial involvement is comparatively less common with presentation with stenosis, aneurysm, or dissection of cervicocephalic arteries. You can also present this stenosis and dissection can also present with ischemic or hemorrhagic stroke, and this is due to the vasculitis of the vasa vasorum. Peripheral nervous system manifestations are relatively rare. However, there are reports of sensory motor polyneuropathy, mononeuritis multiplex, autonomic neuropathy, and even Guillain-Barré syndrome that has been described with NeuroBehcet's, and presentation with myositis has also been described. Coming to the investigative diagnosis, first and foremost is brain and spine contrast. If vascular imaging, MR angiogram or MR venogram, or if aneurysm to be ruled out, angiogram can also be done, and DSA can also be done when coming imaging. In parenchymal NeuroBehcet's disease, the most site is the mesodiencephalic junction, that is the junction between the midbrain and the thalamus, as we can see here. The other regions involved is the pons, the thalamus, the basal ganglia, the cerebral hemispheres and the spinal cord, most commonly the cervical and thoracic segment. And characteristically, NeuroBehcet's disease described asymmetric, also symmetric lesions have also been described. And the typical parenchymal lesion is from the posterior limb of internal capsule to the brainstem along the corticospinal tract. This is described as the cascade sign. So here in this diagram, we can see hyperintensities extending from the lentiform nucleus and the posterior limb of internal capsule to the thalamus to the mid. So in this diagram also we can see hyperintensity extending from the internal capsule to the thalamus to the brainstem. This resembles waterfall, hence cascade sign. Diffusion restriction seen with cytotoxic edema. And SWA usually shows minimum hemorrhage, and the lesions usually have contrast enhancement with the ring or dense or dotted enhancement with or without associated leptomeningeal enhancement. MRS usually shows a reduced Na-creatinine ratio, and the lesions may also exert a mass effect. So in this diagram, in the axial flare images, we can see hyperintensity with swelling extending from the midbrain superiorly involving the thalamus and the internal capsule. And there is a diffusion restriction centrally, the diffusion ADC hyperintensity peripherally suggesting a cytotoxic edema at the center surrounded by vasogenic edema. Surrounding vasogenic edema. In the chronic stage, the atrophy is more pronounced, and the presence of atrophy suggests a progressive course of the disease. And there is also rare case reports of optic neuritis in which there is swollen intraorbital optic nerve, which appears hyperintense in T2 and flare with contrast enhancement in the acute phase. And the spine MRA is classically described with the characteristic finding of vagal sign. So there is a central hypointensity set by a peripheral hyperintensity that is resembling a bagel. This is a contrast image hypointensity with surrounding hyperintensity. Cortical venous thrombosis is also described with or without other parenchymal lesions. So here there is superior sagittal sinus thrombosis that is seen in sagittal T2 images and also in MR venogram. And this is another patient with the left transverse sinus thrombosis without any parenchymal lesions. Coming to the blood investigations for diagnosis, elevated ESR and CRP may be seen in acute phase, and HLA-B51 testing can be used as a supportive evidence. As we have seen, it is not included in the diagnostic criteria as such. However, in case of diagnostic confusion, this can be used as a supportive evidence. Serum, and also in this NeuroBehcet's disease, serum inflammatory cytokines have been found to be elevated. Serum TNF-alpha, interferon gamma, interleukin 1 beta, interleukin 6 and interleukin 8 levels were found to be elevated. There is no specific serum marker that is specific but later. And leukocytes is also described up to around 500 cells per liter. In early stages, there can be a preponderance of neutrophils. However, after a few days, it changes to lymphocytosis. The glucose levels are usually normal with NeuroBehcet's disease, and the presence of hypoglycemia should point towards an infective etiology. And CSF oligoclonal bands are usually negative. And there is also elevated CSF opening pressure that has been described with the disease. Raised CSF IL-6 has also been found in NeuroBehcet's disease, however, not a written as such. Coming to nervous dropsy findings, there are no pathognomonic findings for biopsy in a biopsy of neuroBehcet's disease. In acute and subacute stage, perivascular with neutrophils, lymphocytes, or eosinophils have been described with or without necrosis. In later stages, axonal loss and gliosis will predominate, and inflammatory infiltration will be less prominent. In case of skin biopsy, the classical description is with leukocytoclastic vasculitis with neutrophilic or lymphocytic perivascular infiltrates, microvascular thrombi, or neutrophilic dermal infiltrates. So, leukocytoclastic vasculitis is basically infiltration with neutrophils, and the neutrophils were the degenerate form. Cytoclasis refers to degeneration of neutrophils. Been put forward. So according to this criteria, definite NeuroBehcet's the IST criteria should have a neurological syndrome with objective neurological So coming back to the diagnostic criteria for Behcet's disease, definite Behcet's disease should have satisfy the IST criteria for Behcet's disease with the characteristic neurological syndrome with abnormalities in neuroimaging and CSF that is classically described with Behcet's disease, which we have seen before. And there is no better explanation for the neurological findings. Probable NeuroBehcet's disease is diagnosed when there is a neurological syndrome which is described in definite NeuroBehcet's disease with systemic features of Behcet's disease but not satisfying the IST criteria, or a non-characteristic syndrome occurring in the context of IST criteria supported Behcet's disease. So the presence of systemic symptoms is mandatory for the diagnosis of NeuroBehcet's disease. If it is classifying the IST criteria with a definite neurological syndrome with neuroimaging and CSF findings classical of Behcet's disease, it can be classified as definite NeuroBehcet's disease. If either of this is not there, that is the classical neurological syndrome is not there, or it is not fully satisfying the criteria for Behcet's disease, but there are systemic features present, it can be classified as probable NeuroBehcet's disease. Coming to the clinical course of Behcet's disease, around 50% cases are more active. However, 20% have relapses requiring further treatment and recovery. Around 15% of relapses is followed by a progressive disease. And in around 20% of the patient can have a progressive disease, relapses or remissions also. So around 20 to 30% of parenchymal NeuroBehcet's disease have residual deficits. And factors which are pointing towards a poor prognosis include the presence of progressive disease course, frequent relapses, brainstem and spinal cord lesions, presence of headache at onset, and residual neurological symptoms in remission. Compared to parenchymal NeuroBehcet's disease, extraparenchymal disease have a better prognosis. They usually have a monophasic course and recover without deficits. Coming to the differential diagnosis for NeuroBehcet's disease, this mainly include the other primary CNS demyelinating diseases like multiple sclerosis and MOG antibody-associated disease, and other diseases like sarcoidosis and primary CNS angiitis. So presentation in a pediatric age group is extremely rare with NeuroBehcet's, whereas it is more common with MOG antibody-associated disease. And male predisposition is described only with NeuroBehcet's disease, whereas multiple sclerosis usually have a female predisposition, and it is affected equally in MOG, sarcoidosis, and primary CNS angiitis. The clinical presentation with NeuroBehcet's we have seen before. Multiple sclerosis usually have optic neuritis, myelitis, and can have a brainstem syndrome. MOG antibody-associated disease can present with a cortical encephalitic presentation that is less described with NeuroBehcet's disease. Sarcoidosis, the characteristic findings which differentiate from NeuroBehcet's is the presence of isolated cranial nerve palsies and pituitary involvement and aseptic meningitis, which is less commonly described with NeuroBehcet's. Primary CNS angiitis classically presents with headache, focal neurological deficits, and seizures. Coming to the imaging findings, the presence of asymmetric brainstem lesions with edema and enhancement is characteristically with NeuroBehcet's disease, and the atrophy can be seen in chronic lesions. Multiple sclerosis, as we have seen before, as we already know, characteristically present with juxtacortical and periventricular lesions and also optic nerve lesions. And the myelitis is usually short segment partial myelitis in case of multiple sclerosis. MOGAD usually presents with confluent cortical and large brainstem lesions. And in sarcoidosis, there are white matter lesions pairing the U fibers with the presence of pachymeningitis, punctiform parenchymal enhancement, nodular meningeal enhancement, the hypothalamus and pituitary stalk involvement, and cranial nerve enhancement, which is not characteristically described in NeuroBehcet's. Primary CNS angiitis have ischemic infarctions, microangiopathy signs, tumor-like lesions, hemorrhage, and vessel bleeding in angiogram, which is not described with NeuroBehcet's. And presence of extra-neurological involvement is also very important to differentiate between these pathologies. Behcet's usually have recurrent orogenital ulcers, skin lesions, uveitis, and arthritis. Other disease with systemic symptoms is mainly sarcoidosis, which can present with uveitis and arthritis, but the presence of interstitial lung disease and lymph node enlargement is characteristic for sarcoidosis. Okay. So coming to the treatment, so as a general consensus for parenchymal NeuroBehcet's disease, acute attacks have to be treated with IV methylprednisolone. 1 gram can be given for 5 to 7 days, followed by oral prednisolone, 1 mg per kg per day, that is tapered over 2 to 3 months. And the first attack of parenchymal NeuroBehcet's disease can be treated with glucocorticoid alone or glucocorticoid with another immunosuppressant like azathioprine. In case of relapsing, remitting, or progressive course, further increase in immunosuppressant can be tried with mycophenolate mofetil, methotrexate, cyclophosphamide, or targeted therapy. And slow steroid taper has to be done depending on the time of action of secondary immunomodulation. So these are the drugs which are mainly used for the treatment of NeuroBehcet's. First and foremost, for acute episodes, glucocorticoids, which acts as an anti-inflammatory and immunosuppressive, which is given at a dose of 1 gram per day for 5 to 7 days with an oral taper over 2 to 3 months, depending on the suppressant. For maintenance immunomodulation, the most commonly described is with azathioprine, which acts by inhibiting the purine synthesis and reducing lymphocyte proliferation. This is advised to be started at 50 mg BD to be increased to a dose of 2 to 3 mg per kg per day. The other immunomodulatory therapy that can be used is with methotrexate, which is commonly prescribed for chronic parenchymal NeuroBehcet's disease, which acts as a folate antagonist, reducing DNA synthesis at a dose of 7.5 to 25 mg weekly. In case of recurrent relapses with these therapy, further hiking up of immunomodulatory therapy can be done with cyclophosphamide, mycophenolate mofetil. And the important treatment modality used in this disease is anti-TNF agents. So as we have seen, the TNF alpha is one of the main inflammatory mediator that is described in NeuroBehcet's disease, and anti-TNF agents have been found to be effective in treatment of NeuroBehcet's. The usual therapeutic options are infliximab, adalimumab, and etanercept. This acts by TNF alpha blockade. The dose of infliximab is 5 mg per kg IV, given at 0, 2, and 6 weeks, and then continued at once in 8 weeks duration. Dose of etanercept is 50 mg subq weekly, and adalimumab is 40 mg subq every 2 weeks. The side effects include TB reactivation, infections, lymphoma, demyelination, and infusion reactions. And like in rest of the immunosuppressive therapy, screening of TB has to be done before starting. And the other therapeutic option available in resistant cases is tocilizumab, that is an IL-6 receptor blocker. The dose is 8 mg per kg IV every 4 weeks, and key side effects include the risk of infections, hyperlipidemia, and bowel perforation. And rituximab has also been used in treatment of NeuroBehcet's disease in a case-based scenario, acts by anti-CD20 depletion with side effects of infections and infusion reactions. So coming to the guidelines described for treatment of NeuroBehcet's disease, the latest guidelines from the EULAR committee was published in 2018. According to this, the acute attacks have to be treated with high-dose glucocorticoids followed by slow tapering together with immunosuppressants such as azathioprine. In case of severe disease or in failure of first-line therapy or in case of refractory patients, monoclonal anti-TNF antibodies should be considered. In case of chronic progressive NeuroBehcet's disease, also this monoclonal anti-TNF antibodies has been advised. In case of CVT, as we have seen, they have a better prognosis compared to parenchymal NeuroBehcet's, and like extensive immunotherapy need not be started in patients with CVT with Behcet's disease. So they have to be started with high-dose glucocorticoids followed by tapering, and addition of secondary immunomodulation depending on the severity of the disease and the other clinical manifestations. And anticoagulants may be added for a short duration. So the primary pathology in case of CVT NeuroBehcet's disease is mainly due to inflammation that is caused by the activation of neutrophils forming the neutrophil extracellular traps. So anti-inflammatory therapy is the main treatment modality for treatment of CVT NeuroBehcet's disease. Along with this, a short duration of anticoagulants also should be started. So after which, after the EULAR recommendations in 2020, the Japanese National Research Committee has released guidelines for the management of NeuroBehcet's. According to these guidelines, they've used the CSF IL-6 levels as a prognostic marker and as a marker for treatment improvement in treatment with therapy. So according to the Japanese guidelines, in patients with insufficient response for steroids, they've directly gone for anti-TNF therapy with infliximab. And patients who are responding to steroid, they've added colchicine as a treatment modality. And colchicine mainly acts by microtubule inhibition. Therefore, it acts on the neutrophils, which is the main infiltrating cell type described in Behcet's disease. So if the patient has reduction in CSF IL-6 levels with steroids and colchicine, they can be followed up, they can further be continued on the steroid and colchicine alone. In case of chronic, that is the, they've separately mentioned in detail about each of these steps in the further, In case of chronic progressive NeuroBehcet's disease treatment, they've advised with methotrexate. If there is no response with methotrexate, to add TNF-alpha therapy with infliximab, with which also if there is no improvement, we can consider other biologics like IL-6 inhibitors. After which in 2023, there was another article that is a systematic review on therapeutic approach to CNS involvement of Behcet's disease. This is mainly based on retrospective cohort studies, case series, and case reports. And there are no RCTs available for the treatment of neurological manifestations. So, so according to this, so in this review article, they've provided a flow of the treatment of parenchymal and vascular NeuroBehcet's disease. In case of NeuroBehcet's disease, so in all neurological manifestations of Behcet's disease, calcineurin inhibitors like cyclosporin has to be discontinued because cyclosporin most commonly used therapeutic agent for treatment of systemic Behcet's disease. However, the cyclosporin has neurotoxicity as such, and it has also been shown to worsen the neurological manifestations in Behcet's disease. So the first step will be to discontinue the calcineurin inhibitors if it is still ongoing. In case of acute NeuroBehcet's disease, pulse glucocorticoids followed by tapering. And to prevent relapses, add colchicine in association azathioprine for less severe cases. If insufficient response or relapses with glucocorticoids and azathioprine, we should add TNF-alpha inhibitors, that is infliximab. The dosage is 5 mg per kg at 0, 2, 6, and further at every 8 weeks thereafter. Just further relapses with infliximab, we can either increase the frequency between the doses of infliximab, or we can switch TNF alpha monoclonal antibodies like adalimumab or etanercept. If there are further relapses with anti-TNF monoclonal IL-6 inhibitors like tocilizumab. In case of chronic progressive NeuroBehcet's disease, low-dose glucocorticoids is advised along with methotrexate, that is to be started at the diagnosis itself. If there is insufficient response, we can consider TNF alpha monoclonal antibodies. And with that also, if there is further relapses or disease progression, we can consider IL-6 inhibitors with tocilizumab. In case of vascular NeuroBehcet's disease, steroids along with anticoagulation with low molecular weight heparin is advised for 1 month, after which, depending on the severity of the disease, anti-TNF alpha monoclonal antibodies can be considered. And before starting anticoagulation, we have to rule out any coexistent aneurysm or dissection in the patient. In NeuroBehcet's disease, pulmonary artery aneurysm is also described, so this also has to be excluded before starting anticoagulation in these patients. Infliximab is widely available and it is used for rheumatological and also treatment of inflammatory bowel disease also. Cost is around 17,000 for 100 mg vial market price. So as I've discussed before, the treatment of CVT, the primary pathology behind the CVT in case of NeuroBehcet's is due to inflammation. So anti-inflammatory therapy is the most important factor in treatment of CVT in NeuroBehcet's. So along with that, anticoagulation is also to be given. The duration in which the anticoagulation has to be given is different in different articles that has been mentioned. Some of the articles suggest a duration of up to 3 to 6 months, whereas some other articles suggest 12 to 18 months. There is no definitive data with a randomized control trial that is available that is compared between a short duration or long duration anticoagulation. And regarding the use of direct oral anticoagulants, there is no data with respect to NeuroBehcet's disease. But along with this, a complete thrombophilia work is also warranted in this patient to decide whether further anticoagulation is required. And also in case of isolated CVT without parenchymal lesions, secondary immunomodulation is either it can be started with a low potency immunomodulation like azathioprine. Further, hiking up of the secondary immunomodulation is to be considered only in case of relapses. So with this, we can look at some case vignettes from our institute. First of all, the case which we have seen, male presented with recurrent neurological events present over the last 5 years, and the family history was negative in these patients. On examination, he had oral and scrotal ulcers with scanning dysarthria, left INO, cerebellar signs with bilateral gaze-evoked nystagmus, upper and lower limb incoordination, and ataxia. There was also bilateral corticospinal tract involvement with bilateral upper and lower limb spasticity, exaggerated deep tendon reflexes, and extensor planta. So here the anatomical structures involved include bilateral cerebellum and its connections, bilateral corticospinal tract, and left INO suggesting a left midbrain and or pontine involvement. And the clinical presentation of the patient, the age group of the patient with a 33-year-old with recurrent presentations as relapsing disease with partial response to steroids. First possibility would be to consider a demyelinating disease. Primary CNS demyelination will be the first possibility, among which, since the patient had only partial other systemic vasculitis, which neuro with this, the patient patient's clinical condition remained stable and there were no further relapses over the next 5 years. And he also had a residual ataxia and dysarthria. Sensory tracts of the left hemisphere. So, and the presentation in a 29-year-old male with partial improvement to steroids and worsening on tapering steroids. So here again, demyelinating etiology will be the first consideration, as the patient had an improvement with steroids with further worsening on tapering the dose of steroids. And among the demyelinating condition, with the presence of headache and vomiting suggesting a possible meningeal involvement, a MOG antibody associated disease has to be considered. Among the other causes of secondary demyelination, NeuroBehcet's will also be considered due to the involvement of significant presentation with the brainstem syndrome. So here imaging showed hyperintensities in ventral medulla and the pons, mainly involving the left side extending to the left MCP. And this lesion in the pons also showed blooming in SWI. And there was also contrast enhancement, punctate irregular contrast enhancement in these lesions. So further evaluation showed positive CRP levels with normal peripheral smear. Rest of the vasculitic workup was negative, and aquaporin for MOG antibody was also negative. The CSF analysis showed 540 cells with 80% lymphocytes and elevated protein with normal sugar. And pathology test was positive, and the skin biopsy was again suggestive of leukocytoclastic vasculitis in this patient. So here, again, the patient has systemic features suggesting NeuroBehcet's disease. However, the ISG criteria for NeuroBehcet's disease is not classified, not complete in this patient. And also the clinical presentation is with a syndrome that is classical for NeuroBehcet's disease, and the imaging findings are also the ones typically described with NeuroBehcet's disease. So this can also be taken as a case of probable NeuroBehcet's disease. And this patient was also treated with oral steroids, which was slowly tapered over 1 year and was further continued on low dose steroids. And the patient did not have any further relapses for 4 years, and however, he had residual deficits. Another case is of a 41-year-old male presenting with a 1.5-year history of progressive slurring of speech, imbalance on walking, and incoordination of limbs. He had a history of recurrent oral and genital ulcerations. On examination, had scanning dysarthria, left INO, bilateral gaze-evoked nystagmus. He had a right UMN facial palsy, grade 1 spasticity of right upper and lower limb, exaggerated deep tendon reflexes on the right side with extensor plantar, bilateral upper and lower limb incoordination, and presence of rubral tremor bilaterally with an ataxic gait. So here there is involvement of bilateral cerebellum and its connections, and the left corticospinal tract is involved, and left INO suggesting a left midbrain or pontine involvement. And the presence of rubral tremor bilaterally suggests again a midbrain involvement with the involvement of red nucleus bilaterally. And the patient also has a history of recurrent oral and genital ulcers, which should point us to evaluate for underlying NeuroBehcet's disease. His imaging showed hyperintensities involving the midbrain extending to the thalamus, mainly involvement of medial thalamus bilaterally. And the coronal section is also showing involvement of the medial thalamus bilaterally extending to the midbrain. SW is showing mineralization of the red nucleus and the substantia nigra. And the lesion was not diffusion restricting or contrast enhancing. So in this patient, ESR and CRP was normal, ACE levels were also normal, and pathology test was negative. And the vasculitic workup was also negative for the patient with the aquaporin for MOG antibody was also negative. The CSF evaluation showed 5 cells with 100% lymphocytes and protein of 72 elevated protein of 72. The rest of with normal sugar levels, CSF malignant cytology and CB-NAT was negative with normal nerve conduction studies and BEP. So in this patient, the patient has oral and genital ulcers, which is suggesting towards the systemic features of NeuroBehcet's disease. This patient also, the IHT criteria is not satisfied. However, the patient has systemic features of NeuroBehcet's disease with imaging, clinical, and CSF findings that is classically described in NeuroBehcet's disease, classifying as probable NeuroBehcet's. He was also treated with steroids and with symptomatic treatment, and steroids were slowly tapered and stopped over 5 years. There was no further worsening over the last 10 years. However, he still has residual deficits from the disease. Coming to the fourth case, is of a 22-year-old male who presented with complaints of blurred vision and headache of 3 months duration with recent onset horizontal binocular diplopia and vomiting. He had previous history of recurrent painful oral and genital ulcers since 13 years of age, which used to occur once in 2 to 3 months. On examination, he had visual acuity of 6/9 on the left eye with bilateral grade 3 papilledema, and bilateral abduction was restricted. So these are the scrotal ulcers that was present in the patient. Then this is grade 3 papilledema with vascular scarring that is suggestive of retinal vasculitis. And his imaging, sagittal T2 image is showing cortical sinus thrombosis involving the superior sagittal sinus. And we can also see features of raised ICP with tortuous optic nerve and perioptic nerve sheath widening. So along with that, the rest of the workup showed elevated ESR of 52, and the vasculitic profile with ANA, APLA, Anagha, VDR and ACE levels were negative. He had an HLA-B51 positivity, and the pathology test done was negative. So here also the patient has systemic features of Behcet's disease with presentation with CVT. He was treated with injectable followed by oral anticoagulation along with anti-edema measures and oral steroids, and was continued on secondary immunomodulation with mycophenolate mofetil. With this, he had symptomatic improvement and the fundoscopic picture also improved. So the take-home message is that NeuroBehcet's should be considered as a differential for brainstem systemic manifestation. Typical venous thrombosis cases should be evaluated for NeuroBehcet's in the presence of systemic symptoms or parenchymal lesions which cannot be explained by venous infarcts. The diagnosis of NeuroBehcet's disease, we have seen the diagnostic criteria. It is mainly clinical and radiological. The genetics and histopathology can only aid in the diagnosis. I think I have covered the management aspects of Behcet's disease and demonstrated as the various presentations which can link to other diseases, which can link to other diseases and finally in terms of NeuroBehcet's. So the NeuroBehcet's is important secondary for demyelination and first one is the normal presentation, which is very frequently involved in NeuroBehcet's. Actually, we should give a differential diagnosis in this demyelination and neuroinflammation. And having a chronic CNS infection is needed most differential diagnosis. Here is not very comfortable with treating. The diagnostic criteria is probably relies on historical assessments or the ulcerations. It can be easy to miss if you're not specifically asking for this. So you need to have a very high index of suspicion, a proper history taken, otherwise you are not able to diagnose. And third point, first is immunological disorder with multisystem involvement, strong is not Wind up the session. Thank you.